Hello and welcome everyone. We are now into week 8, the last and final week of our knee injury rehabilitation course. In this week, we will learn about return to play criteria, the re injury risk reduction, and long term knee health. My name is Major Amar. I'm Assistant Professor, Department of Sports Medicine, AFMC, and I'll begin with lecture number 36 today. Lecture number 36 is about evidence based return to play guidelines for knee ligament injuries. The objectives for today's lecture are to understand the concept of criteria based versus time based return to play, to learn validated functional and strength tests for return to play decision making. We will also identify sport specific considerations in return to play after ACL, PCL, MCL, and multiligament injuries. We will try and understand the risk of premature return and strategies to minimize the re injury. We will recognize psychological readiness as a key determinant of return to play. When is an athlete truly ready to step back on the field? When can he resume training? Or can you answer, when should he start competing? There are so many questions regarding an athlete's return to active participation in sports. Time since surgery alone doesn't give us the answer. Time elapsed since injury or surgery does not tell us about the quality of rehab undergone by the athlete. Return to play must balance the biological healing of the injury with the functional readiness of the athlete. This functional readiness can be determined by return to play criteria. However, the evidence based guidelines only provide the framework for the medical caregivers to design the program. They are not our or anybody's personal opinion. A rehab provider must therefore alter the rehab plan for an athlete depending on the athlete's personal goals and sporting requirements. Before we move further ahead, let us first discuss some of the terms that are interchangeably used in sports. I am talking about RTA, RTS, RTP, and RTPerf. RTA, which is return to activity, is resumption of general daily physical activity like walking, recreational exercise, gym work, without necessarily engaging in a structured sport. This stage focuses on safe reintegration into functional movement and lifestyle activity following an injury or a surgery. It does not require full athletic performance or sport participation. It is often an intermediate goal before progressing to sport specific rehabilitation. RTS or return to sport is when an athlete resumes participation in their chosen sport, which may be at any level of training. It may even be a modified practice or a proper competition. RTS is a broad category that includes modified practice sessions and non competitive play as well. It does not necessarily mean full return to competition. The emphasis is on sport participation under controlled and progressive conditions. It marks the transition from rehabilitation to structured sport reintegration. Coming to RTP, which is return to play, it is the clearance for unrestricted training and competition at the pre injury participation level. RTP implies the athlete has met clinical, functional, and psychological criteria to resume full competitive participation. It represents the endpoint of medical clearance. This stage carries the highest risk of re injury if criteria for return to sport are not rigorously applied. Lastly, RTPERF. RTPERF stands for Return to Performance. The athlete not only returns to competition but regains or exceeds their pre injury performance level. RTPERF focuses on achieving optimal sport specific performance, not just participation. It often takes longer than RTP and includes physical, technical, and psychological optimization. This is the true benchmark of successful long term rehabilitation in elite athletes. Historically, athletes were cleared to return after a fixed time. They were cleared to compete as and when they were able to achieve complete range of motion and were ambulatory. But studies show that many still had deficits in strength and control at that point, and many were still not fit to compete or fit to participate in the sport of their choice. This was due to lack of any objective parameters or tests to gauge the readiness of the athlete. The risk of re injury in these athletes was very high. Evidence shows that criteria based decision making dramatically reduces re injury rates. It's no longer about the calendar and time, but it's about readiness of the athlete. It's no longer about the calendar and time since surgery or time since injury, but it is about the readiness of the athlete. Across all knee ligament injuries, the general principle of rehab remains the same: to achieve complete and pain free knee range of motion with no swelling and no subjective instability. Muscle strength symmetry between quadriceps and hamstring of the injured as compared to the uninjured limb should be at least 90 to 95%. This can be measured objectively either by using an isokinetic dynamometer or using a handheld dynamometer. Finally, the athlete must be able to safely and confidently demonstrate and execute sport specific drills before clearance to return to play. While performing these drills, it is important to identify and correct any deficit in the biomechanics or quality of the movement. Quality of movement should take precedence over the number of sets and repetitions of any exercise that the athlete can perform. Now let's discuss about functional performance tests. The leg hop tests are widely used functional performance measures to assess readiness for return to sport after knee injuries. The four most validated tests include the single hop, the triple hop, and the crossover hop. All these three tests are done to measure the distance, while a 6-meter timed hop test is used to measure the power and endurance. These tests evaluate lower limb strength, dynamic stability, neuromuscular control, and symmetry between the injured and the uninjured limb. Agility tests like shuttle runs and T tests assess direction changing ability. The Y balance test evaluates stability during dynamic reaching, but it's not just numbers. The quality of movement is equally important. Proper landing mechanics include athletes landing on their toes with a knee flexion between 10 to 30 degrees. One of the strongest predictors of re injury is poor landing mechanics, especially dynamic valgus collapse. Gross dynamic valgus is obvious to the naked eye, but subtle movements can be missed by observers. Hence, a video analysis or motion lab setting can identify these risks and help us correct them. Neuromuscular training, including plyometry exercises and balance training, reduces risk and improves dynamic control. We must look beyond muscle strength because strength in itself is not enough. The ability to move with correct posture will ensure lesser re injury risk. Even if the knee is strong, fear of re injury may prevent safe return. The ACL RSI scale helps measure confidence. ACL RSI scale is a 12-item self supported questionnaire scored on a Likert scale of 0 to 100. Items assess emotions, confidence, and risk appraisal related to return to sport. The primary purpose of the scale is to evaluate the psychological readiness of athletes following ACL reconstruction before the athletes return to sport. Higher scores indicate greater confidence and readiness. A cutoff of more than 65 points is often associated with successful return to sport, whereas lower scores suggest psychological barriers and higher re injury risk. Athletes who lack psychological readiness compensate with unsafe movement patterns, increasing incidence of re injury. Counseling and graded exposure to sport specific tasks are essential parts of rehab. This responsibility primarily resides with the sports medicine physician, the strength and conditioning coach, and the sports psychologist. The ACL is the most studied injury of the knee. Evidence shows that returning earlier than 9 months increases the risk of re injury by 2 to 7 times. Athletes must pass hop tests and have good strength symmetry before clearance. Neuromuscular control is often checked in these athletes as discussed previously. Delaying RTP and meeting criteria dramatically lowers graft failure rates and hence reduces risk of re injury. Slide number 11, RTP after ACL reconstruction. Last point. Delaying Last point. Delaying RTP and meeting the criteria laid down dramatically lowers graft failure rates and hence reduces risk of re injury. Slide number 12, RTP after PCL, LCL, and MCL injuries. PCL injuries require more cautious return due to posterior loading. Clearance is usually after 9 to 12 months with strength and balance restoration. Isolated MCL and LCL injuries, in contrast, often allow return in 8 to 12 weeks if the criteria for RTP are met. Isolated collateral injury cases are usually of low grade injuries and hence the RTP is sooner. For combined injuries, timelines extend significantly and require stricter thresholds for progression in a rehab protocol. With multiple structures injured, clearance often takes well beyond 12 months. Rehabilitation in such cases is complex, balancing healing of different tissues while improving the range of motion and loading of the tissue is no easy task. And it requires a lot of patience by the athlete and skillful monitoring by the rehab team. Athletes require extensive functional and psychological assessment as well. Unfortunately, many fail to return to pre injury competitive level in such cases. Evidence shows that only 20 to 25% of athletes are able to achieve their pre injury level of performance once they make a successful return to sport. Premature return to sport is dangerous. In young athletes, up to 30% suffer re injury within 2 years period. Early RTP doubles ACL graft failure risk. If such psychological readiness is lacking, unsafe movement patterns emerge. This is due to either inadequate neuromuscular control or hesitation in performing sport specific tasks. Each re injury accelerates degenerative changes, raising osteoarthritis risk in the long term. In practice, clearance requires multiple checkmarks: lack of symptoms like no pain or swelling, good objective scores like more than 90 to 95% strength symmetry, passing hop or agility battery of tests, psychological readiness confirmation after questionnaire based test, and surgeon and physician and the support team joint consensus. This integrated checklist ensures a safe and successful return to sport. With this, we come to the end of lecture 36. The key takeaways are that RTP decisions must be criteria based and not just time based. Functional as well as psychological assessment are both crucial for an athlete to make a successful return to play. Premature return to play risks are high and preventable, and a multidisciplinary, individualized decision making is essential for an athlete to make a successful return to play. These are some of the references I used in the lecture today. Thank you for your time. Have a good day.